I think we are going to start. And I'll start with the introduction. So we are really thrilled today to have one of our own, Kristen Miller, to talk about applying human factors to alert design. So before I introduce our speaker, let me go over some housekeeping issues. Please make sure you sign in. RSVP so that we can better prepare for the next session. Online participants, please keep the mics muted unless asking a question and keep video turned off. Next, we'll have some break before returning on May 13th for innovative strategies for engaging rural populations by powering services and tech. And then we'll have new strategies to identify genes linked to human birth defects by Sally Lackley from UD on May 20th. So the next conference are May 13th and May 20th. The full schedule is on the ACCEL website, and all the previous presentations are on the website, DE-CTR.org. So we are really happy today to have Kristen. Kristen is Associate Director for Human Factors at the Value Institute. She has a Bachelor in Public Health Studies from Johns Hopkins, a Master of Science in Occupational Health from Texas A&M, and a doctorate in public health in epidemiology and environmental health also from Texas A&M. Prior to coming to Christiana Care, she was faculty in the Department of Public Health and Health Sciences at University of Michigan in Flint, and also a senior research fellow at the Department of Veterans Affairs at the National Center for Patient Safety in Ann Arbor, Michigan. She has had multiple awards and the last one was nominated in 2015 for the William C. Howell Young Investigator Award. And although she's been only here for less than 2 years, she already has multiple publications for Christiana Care projects. Very interesting. And she is also a co-investigator on an NSF grant about sepsis early prediction implementation system, and also on the CTR grant, pilot grant, related also to sepsis. So thank you very much, and we can start.
So I'm really excited today to talk about owning attention and human factors in alert design. I think that alerts are a blight on the healthcare industry. I think many of you would probably agree. If we can make something alert, we do. And there's not always a lot of thoughtful design put into those alerts, thinking about the context in which you see them and how you're supposed to respond to them. So what I want to discuss today is the idea that it's not as easy as I want to tell you this thing, so here's this thing. And have you all walk away from here understanding that designing, creating, and responding to alerts requires a lot of effort. So maybe because I've been in the world of clinical decision support for a long time, this is really clear to me. The definition defined as providing clinicians with clinical knowledge and patient-related information, which is intelligently filtered and presented at appropriate times to enhance patient care. When we did some preliminary work, specifically to bring along on her practicum, we worked with the nursing councils, and this was one of the first questions, and they all raised their hand and said, we're not clinicians, we don't get clinical decision support. And I think the misconception is that clinical decision support is that pop-up to say there's a drug-drug interaction or there's a drug allergy for the patient. But clinical decision support is so much more. It could be that drug alert. It could be a recommendation for a different antibiotic based on clinical guidelines. It could be a recommendation for a diagnosis based on the symptoms that you put into the chart. It could be a recommendation for different radiological exams and imaging based on guidelines. But it could also be the barcode scanner. So thinking about Dominique's work, if you just gave an opioid a few hours ago, now you go to give another opioid, that bar scanner could say, hey, now you're putting this patient at risk for oversedation, so maybe hold off on that. And that's also clinical decision support. Or Muget's work with cues. Your patient is at risk for deterioration. That goes to a nurse, right? That's also clinical decision support. So in a sense, any computer system that deals with clinical data or medical knowledge is intended to provide decision support. And we think about where all of this information can come from. So obviously things that are in the electronic medical record, so all the different nursing assessments that go on, vitals, labs, images, and then the medical devices that then talk to the electronic medical record. So in a few months, Christiana will have the infusion pump management integrated into the EMR. So now the record is talking to the pumps. We also have bedside monitors. So when Satera goes live, continuous vital sign monitoring going into the EMR. And then where this information is pushed out to. So the financial system, so for coders getting different diagnoses. So trying to understand it's a much bigger system. And because of that, these systems are multidimensional, they're complex, and they require in-depth interdisciplinary approaches to understand their impact. I feel really fortunate to work at the Value Institute with colleagues like Muge, who's creating these really complicated algorithms to predict patient deterioration, and Sharon Cleveland from IT, who can create this really smart logic in alerts that says, hey, your patient is over 65, they're also female, you just ordered this drug and now you're putting them at risk for falling, so maybe think about different therapies. But I think algorithms alone are not going to save patients, and that's where the human factors piece come in. So addressing these human factors issues that are inherent to implementation science as a complement to the work of the predictive analytics. So obviously there's a role of healthcare information technology in preventing errors. First, it can provide availability of information to clinicians. So you think about paper records 10 or 20 years ago where somebody has to go through that whole chart to understand what's going on with the patient. And now that information is available right at your fingertips. Improving collaboration between clinicians. So we know that patient care is not just one person. There's the physician, there's the nurse, there's the respiratory therapist. Everybody really needs to have this information because it's electronic. Everyone can see everyone else's notes. We can reduce human error at the point of care. So in human factors, we talk about the sharp end and the blunt end. The sharp end is that person that's about to do something really terrible, even though it's not their fault. And that's where we can build in some of these technologies to capture that. So again, the barcode scanner being the best example. You used to go to the pharmacy, you'd grab a bag of medication, you come back, you're about to infuse it, and now the barcode scanner says, hey, wait, that's actually the wrong baby, or that's the wrong medication. And then whenever possible, providing workflow automation and improvement. So does healthcare information technology improve safety and quality? There's a lot of research that says yes. So computerized physician order entry, again, thinking about that drug-drug interaction where 20 years ago, a doctor would write a prescription on a piece of paper, and then it goes in, and now it's administered. Now you're putting that order in, and there's all this logic happening in the background that's identifying, hey, maybe this is not the most appropriate drug. Again, barcoding, lots of research to demonstrate that that is improving quality and safety. And the electronic medical record. So again, this idea that all of this information is now available to you and it's going to help you improve the quality of care that you're providing. But electronic medical records concerns are outstanding, and not in a good way, outstanding, but have been around for a really long time. Cost, not just the cost to develop the EMR, but to personalize it to your own institution, to teach people how to use it. There's some research that demonstrates increased rate of errors, adverse events, and mortality. And part of that is that now it's much easier for us to detect those because they're all electronic, but also that people are depending upon the EMR to help them make decisions, and when technology fails, then they fail. The number of steps to complete the task, so thinking about all of the nurse assessments that they're doing and how they have to sort of manage through different screens, and what if they're not familiar with that system. Inexperienced vendors, so the vendors are really good at making the IT system, but they may not consider the context or the workflow. Problems with data entry, we just talked about this today, so you can put in negative heart rates, and that's okay, which Ryan told us you have to be really sick to heart rate. There's errors with key bounds, so maybe you meant to write 10, but you hit that 0 twice, and now it's 100. because it's not handwritten and there's just a box that only accepts numbers, sometimes we can't tell if the temperature you put in is Fahrenheit or Celsius. We don't know if the weight is standard or metric. With new HIPAA laws, there's a lot of concern with confidentiality and security. And then I would argue the biggest problem is the lack of standardization. A lot of my examples come from the VA, which is where I was before this. And the adage was, if you've been to one VA, then you've been to one VA, because everything is different, even within that 153 hospital healthcare system. We like to personalize things here, and so we do. So every system is different. So physicians that work at Nemours and then come to Christiana and then come to Jefferson, maybe they're on Cerner and then they're on Epic. Or even if it's the same system, maybe it looks totally different. One of the bigger projects before I left the VA was to create a tracking system so that we could identify patients who had an implant that was recalled. And it's amazing to me that Acme can tell you everything I purchased in the last year and a half, but we can't identify patients who have a bad hip that we now need to replace because we can't find them. And if we can find them, we can't find their primary care physician to reach out to contact them. So lots of money, probably millions of dollars, went in to create this tracking system, and at some point they just threw the whole thing out because it wasn't reliable, it wasn't credible, and there was poor consistency. We also see a lot of issues with problematic user interface design, which is what the person is seeing, that front end display. One of my favorite things about human factors is the idea of unintended consequences. So we really don't know to what extent technology design has caused patient safety problems. We'd like to think that we're helping people and we're saving lives, but in reality, we might actually be doing damage. Ellen Bass, who's one of our collaborators at the University of Drexel, had said, it's as if we created a plane and we sold it to an airline company and said, here's the plane, works great, you do whatever you want to the cockpit. You put buttons wherever you want them, you can make different graphs, you move those displays around. I mean, that would be absolutely crazy, but that's exactly what we've done in healthcare. That anyone can manipulate the system to make it look however they want. So a couple of observations with respect to tools and monitoring in general. One, we don't use a single tool to gain insight into the architectures that we build, and we never will because the systems are so complicated. We're not talking just about what happens in the EMR, but we have to include things like conversations with the patient, conversations with your colleagues, talking to the family. Teams of people are the norm, which means communication and coordination will become as important, if not more important, than surfacing anomalies themselves. So we know if there's an alert that comes from vitals a patient care tech put in, we now need to alert that nurse, and then we need to alert that physician. And so thinking about that whole care team. We bring our biases, expectations, trust, and perceptions to the table, and no tool or automation or tooling will ever change that. And understanding the breakdowns at these boundaries between people and machines should be a part of how we approach the design of tools and organizational behaviors. And we try to do this through human factors engineering, which is the study of human physical and cognitive capabilities and limitations, and the application of that knowledge to system design. Human factors as a discipline is really interesting because it grew out of two different disciplines, cognitive psychology and industrial engineering. So on the cognitive side, you have people that look at things like teamwork, communication, culture. And then in the industrial engineering side, more of the physical. So the layout of a patient room or the use of a piece of medical equipment. And the alert design piece really incorporates both because it's the design of the interface between people and technology. So looking at the man-machine interface. There's a lot of research that says effective presentation of alert, including two things, how and what is displayed, can offer better cognitive support during particularly busy patient encounters and helps providers extract information quickly. So what we'd like to do is create a human factors alert framework tailored to clinicians with the goal to better equip them to understand their patient's data through feature extraction and visualization. So even with a lot of research in this field, Unfortunately, these researchers fall prey to the same problems that we do in responding to alerts. Micah Ensley, who's pretty famous in the world of situational awareness, that's her research, was telling a story how she presented at a safety conference for safety professionals. 300 people in this big hall, and not prompted or planned, the fire alarm went off. And 3 people got up and left the room. So this is like a safety conference, people that do safety. So I don't know what's in there, but I think it speaks to some of these issues. I'd like to read you some quotes and then tell you who said it. So these are real people in real jobs. Quote, "The whole place just lit up. I mean, all the lights came on. So instead of being able to tell you what went wrong, the lights were absolutely no help at all." It's a comment by a space controller in mission control after the Apollo 12 spacecraft was struck by lightning. Quote, "I would have liked to have thrown away the alarm panel. It wasn't giving us any useful information." Comment by someone who was interviewed after the 3 Mile Island nuclear power plant meltdown. And then the last one, quote, "When the alarm kept going off and we kept shutting it off and then it would go off and we'd shut it off again, I reset it to a higher temperature, so I just kind of fooled it." Physicians explaining how they respond to nuisance alarms in the OR. So one of the biggest questions here is what's more important, content or design? And at this point, I think I have more questions than I do answers. And I'm hoping that you weren't coming here to get answers. We're lunch. But, I would argue that it's you. Like, content and design are both equally important, but really it's how you use something. So signal detection theory, if you have any psychology background, this will be really familiar to you, but it's the idea that in any given set of measurements, there's the thing that you're looking for, the signal. There's everything else that's unrelated, that's the noise, and they always overlap. And so we're able to tune the sensitivity within this to create our alerts. So if you wanted to make sure that you captured 100% of the people that had, say, sepsis, you're going to have a lot of false alarms because there's a lot of noise. If you said, I only want to capture people with sepsis and not people that don't have sepsis, then you're going to have a number of missed alarms because there's that overlap of that noise. And this tuning exercise is what we do with sensitivity and specificity to create the alerts. But I think we have to understand the context in which people receive alerts. What are they doing when there's a missed alarm? What are they doing when there's a false alarm? And cognitive overload is a very real thing that can be very hazardous. And as it turns out, cognitive underload is also a thing. Could be equally as dangerous. So in healthcare, cognitive overload is referred to as alert fatigue. So it's the idea that there's so many alerts coming at you, they're consuming too much time and too much mental energy, so you just start ignoring them, or you misinterpret them, or you select the wrong ones that you're going to respond to. I think cognitive overload is like a whole hour-long lecture on its own, but something that we really need to be cognizant of in healthcare. So thinking about how people respond to alerts, I think in general, we create these alerts and we think, I made this alert, they're going to love it, it's going to be awesome, they're totally going to get it. But there's so many things that happen when you receive that alert. And so trying to understand that context. There's a lot of questions that you ask when you get an alert. So a lot of my examples are also sepsis. A patient, a nurse on a medical floor receives an alert right now that says, hey, your patient is septic. The person that made that alert is like, it's great, they got it, right? But that nurse is probably thinking, okay, do they have sepsis? Do they have septic shock? Is this based on vitals? Is it Sears criteria? Because I might not trust that. Did they get up to go to the bathroom and now their vitals spiked and I need to change the thresholds? So a myriad of questions that come out of this design where somebody thought, oh, they're totally going to get this, right? And they're going to respond the way that we want them to. Some research, just to, not to scare you guys, because you're in healthcare and you already know this, but just in general, ECRI puts out this top 10 list of technology hazards they have for years, and missed or alarms in general has been on there for the last 7 years, somewhere in that top 10. And they're talking about monitors and alarms that are designed to never miss. So things like blood glucose, blood pressure, EKG, EEG. And they found there were, from 2005 to 2008, 566 deaths related to alarms. And the majority of these were associated with silencing. So for those of you in clinical care, you can see how that would happen, right? An alarm goes off, you silence it, you go back to what you're doing, and now all of a sudden there's this other patient that you need to go see and still silenced. We could have long discussions about how you can silence something locally and nobody knows and you don't respond to it, but just the fact that that happens, but that's a pretty significant number of deaths, I would say, for something that's preventable. Looking at the problem on a bigger scale, so 2014, a study coming out of California that looked at alerts, and in this case, not just physiologic alerts, but also things like bed alarms and call bells. Looked at 5 ICUs with 66 patient beds and found 2 million alerts per month. That's approximately 187 alarms per patient per day. Like, the clinicians are not shocked, but I think the researchers are like, oh my God, that's so many alerts. How are you supposed to respond to all of those in an appropriate way? Looking just at computerized physician entry order, a 2009 study out of Beth Israel found, looking at 3.5 million electronic orders, that 3 to 6% generated alerts. 3 to 6% is like not a lot, kind of rare, but that's 233,000 pop-ups. And 90%, over 90% were overridden. If something's being overridden 90%, then you have to question, should that alert even be going off? And then totally different, a study out of the VA in Texas looked at notifications for primary care physicians. So not alarms, not alerts, but notifications, something in their inbox that says these lab bodies came back, this imaging result came back, and found that they were dealing with, on average, 77 alerts, upwards of 113 in one shift. And the burden required to deal with that is over an hour. So that's 1 hour where you're not doing patient care, you're not at the patient bedside, and maybe it's like an 8 or 10 hour shift. That's a pretty significant part of your day. So because there's false alarms, this brings us to confirmation bias. And we're human and we're adaptable, so we need to confirm that things are real before we deal with them. There was a study about 10 years ago looking at pilots, and they discovered, I had to write it down, delay in ground proximity warning system syndrome, which describes a pilot's delay in responding to the ground proximity warning, like the ground is getting really close to you, 73% of the time. So 73% of the time, the first thing the pilot did was look out the window. And I think it indicates how often this alarm is wrong. The fact that they need to see with their own eyes what's going on. There's the self-serving interest for pilots as well, because they need to land safely. So it's a little different than healthcare. But what are ways that we can address confirmation in our alert design? Then you think about expectancy. So oftentimes, because of what you're doing, you might expect or anticipate to see an alert. In a study in the operating room, 6% of alerts were found to be expected or anticipated. That doesn't really sound like a lot, 6%, but you start to wonder which ones did you anticipate and now you're ignoring, and which were the ones that were actually really significant. So what are ways that we can support expectancy in alert design? Signal to noise ratio is something that we've been dealing with for years, and it's very difficult. The air traffic control industry fixed this by moving the sensitivity so that they capture everything. So they're okay with a 65% false alarm rate because the missed alarm rate is 0.2. And I would argue in that industry, the errors are catastrophic. And so it's okay to have a 65% false alarm rate because that's what they're doing, is making sure planes don't crash into planes. But in healthcare, when there's alerts for diagnosis, there's alerts for treatment, for warnings, for, It's not reasonable to have that high of a false alarm rate for all of these different systems. So what we do is err on the side of false alarms, and that results in this decay in trust. And I want to point out that it's not the surfacing of anomalies. We're pretty good at that. It's the system that we've built to do that. So there's things that we can't detect. Thinking like about the Q's work, if we're only taking vitals every 8 hours, it makes it really hard to predict who's going to deteriorate, as opposed to continuous vital sign monitoring. That's my plug for continuous vital sign monitoring, because you're able to capture trends in what's happening. So in the early 90s, there was some research that recommended how you can apply human factors engineering to design thinking. So pretty basic. Technologies need to be designed for and to work with people. So we always try to bring in clinicians. Again, people that design alerts are really good at building the alert, but maybe don't know what is it that you want as a clinician. What do you want to see? How do you want to see it? Systems must be designed to accommodate the range of users. So thinking about an alert that's good for a novice nurse, but also a tenured nurse, for someone that's been working a double shift versus someone that just came on, and thinking about that whole range. How systems are designed will influence human behavior and therefore system performance. At the Value Institute, a lot of us do process mapping. It's fascinating to me, right? So the first thing you do is make this map, step 1, 2, 3, 4, off of clinical guidelines or policies. Then you talk to an administrator, like a nurse manager, and you say, how do you really do it? And it's like a little bit different. Then you follow someone and you watch what they actually do, and it's totally different. So, I mean, the point is you can't predict what humans will do, and that's going to impact the system performance. Design needs to be evidence-based, not common sense or designer-driven. I care about what people want, but we saw this in the redesign of the Women's and Children's Tower, where we mocked up rooms and we brought nurses in, and the first group said, hey, this is really great, but can this counter be standing height? Because when I talk to the patient, I want to stand and have my computer right there. We thought, that's great. All right, standing height. Then the next group of nurses came in and they said, if you can make this a little lower, I like sitting there, eye-to-eye contact with the patient. All right, throw that first suggestion out the window. Right, so we care about what's happening, but we want to put it in the context of evidence-based. And lastly, all designs must take into account the system of use. So again, thinking about, are these alerts going to work when we're at capacity, when it's normal, when it's holidays, when it's weekends, when we're short-staffed? So all of these different things, considering that whole system. So just how there's the 5 rights of medication delivery, right person, right medicine, right time, right route. I think we can create the same thing for clinical decision support. Provision of the correct information to the right person in the right format, through the right channel, at the right time in workflow. So again, this, my personal opinion about alerts. We have really smart systems. Electronic medical record is really smart, and it can take in a lot of information. So because we can input all of this information, we can measure that information. Because we can measure it, we can alert to it, and we do. We alert to everything. So it's not the information that's scarce, but it's the attention. So really, alerts are directed attention. They're trying to get your attention at a certain point in time. By understanding how human factors works and its relationship to things like context and perception and workflow, I think we can better design alerts. And thinking about the cost of an interruption or a context switch. That's why people like to work in a quiet room or have really big headphones on, because when someone comes in and says, can I have a second? And then 5 minutes later they leave, because it's never a second, it's 5 minutes. You're at your computer and you have to go back. What was I doing? Oh, I was sending that email. Okay, send. Oh, I didn't attach that file, right? Or for a nurse, I'm programming this pump, interrupted, now I put the wrong dose in, then I started the infusion, right? So these have a really real cost of switching back and forth between tasks. I was doing a lot of research for this presentation, reading about, if you were getting ready to go to bed and you had calmed yourself down and you changed and you're in bed, and then somebody pops in and says, hey, did you read that article about that thing? It was so cool. How long is it going to take you to go back to sleep? And for me, like, I want to read that article, and I want to know this thing, and then, like, an hour later, I'm at the end of the internet taking a BuzzFeed quiz about what kind of pizza I am, or, like, something crazy, and it's so hard for you to refocus your attention. And so we think about interruptions, because that's what alerts are, they're interruptions, and this idea of specification. So there's two things. Here's the data I want you to see, and here's why I think you'll find it interesting. Here's why I think you need to see it. So again, thinking about people that make alerts, and they always think, like, this is great, right? They're totally going to get it. And not understanding the context. And I think that example of someone busting into your bedroom, like, what if all alerts were a person? I'm going to use Ryan as my example. If Ryan's in the ED treating patients, and I'm an alert, and I say, hey, Ryan, that's what the alert does, right? Hey, I want to tell you about this patient that's at risk for falling. And I think about all the things that you could say to me, like, oh, I didn't know that. That's really interesting. I needed to know that. Or can you come back in 3 minutes because I'm doing this thing and it needs my undivided attention? Or no, I already knew that, you know, or go back upstairs because this is really annoying. And that's how alerts are. And I think if we thought about alerts as people, then you would have a whole different perception of how often you should be alerting someone and the reasons that you would bother them. In 2013, California and New York were introduced to the Amber Alert, which was also the government saying, I can now disturb your sleep without any actionable item for you to address. So the very first alert came, I mean, for me, that's the middle of the night, 10 to 2, and woke a lot of people up. And so the alert was for a man named James Lee DiMaggio, who may or may not have killed his friend and her son, burned his house down with them inside of it, and fled with her daughter. They wouldn't know any of that from looking at that alert. And the internet just went crazy about this. There were Twitter articles and MSN articles. My favorite was a headline from that said, Shaquille O'Neal, yeah, I got that Amber Alert. Like, this became a whole thing. And what the internet did was it taught people how to turn off Amber Alerts, which was not the point of the Amber Alert, not really what the authorities were going for. But there were three big mistakes that came out of the implementation of this new technology. The first was that it was a huge surprise, so nobody knew that you could even get alerted for this, and the sound is like really loud and obnoxious and woke everybody up. The second was that it happened in the middle of the night, and we can't predict when bad guys are going to do their thing, but coupled with number one, this really irritated people. And then third, and probably most important, is that there was no clear call to action. So the alert itself is utterly devoid of any useful information, and note that this was the very first. This is a screenshot of the first one, and it says update. So more to the point. What is the situation? It's not telling you what you should do. Amber Alert means there was an abducted child, but in an emergency at the middle of the night, how am I supposed to remember that? It tells you information about the car, so am I to assume that the person's driving this car? And then lastly, what do I do? Should I follow them? Should I intervene? Should I call 911? And so I think, you know, just a demonstration of failing to take advantage of new capabilities when expanding a service and not really thinking again about context. Visual attention, so a lot of research in this field, not what I do, but really cool to think that you can only see 3 degrees in front of you. That's your focus area, and outside of that it's just clutter. So clutter's bad. And then selective attention. How many of you have seen this? Oh, good. More hands on it. Okay. So this is an exercise, so those of you that have done it. There's 3 people wearing black shirts, there's 3 people wearing white shirts, and I want you to count how many times people in the white shirts pass the basketball. many passes?
16.
Did everyone see the gorilla? Did anyone not see a big gorilla? Did you really not?
What's that?
I did. Got 16 passes though.
That's great. You were really focused.
I was waiting for the gorilla.
So here he comes.
That's awesome.
This is one-time thing, so then you're like, Bill, you're looking. So what's really fascinating about this is that when asked to count how many passes people in black shirts had passed, 20% of people missed the gorilla. And I think because you're looking at black and then you see it and it's, sort of in your vision. When asked to count the white passes, 40% of people missed the gorilla. And then if I had asked you to count the number of dribbles and the number of passes, 80% of people missed the gorilla. And I think it demonstrates how the more focused you are on a task, the more selective your attention becomes. It's always worth it when there's people that never seen it. And then we think about scene gist, so exactly what it sounds like. Can you get the gist of a scene? So I'm going to show you 3 pictures super quick, and then I want you to tell me what they are. Classroom. Library. House. Yeah. There's like a Japanese tea cottage, but that isn't it. So your brain is able to process that picture just in milliseconds. And that's what we want to do with alerts. We want someone to know, okay, this patient's at fall risk. Okay, this is a drug interaction. Oh, this patient needs a different antibiotic. We want you to get that just by seeing something. How many of you know what this symbol is? Well, you're smarter than me, because about a year ago, I showed up at the Volkswagen dealer and I said, there's an alert of an exclamation point in between 2 parentheses. It's a signal for low tire pressure. And they, I'm sure, had a really good laugh at my expense after I left.
Look at the little book with the explanation.
Nobody reads the manual. And so the point is that you didn't get the gist of that alert. And now I'm spending time finding the manual. It's not in my car. I'm looking it up online. We want people to understand what we're trying to say right away. Can you find the T in under 10 seconds?
Done.
Everyone find it? Should I start to panic a little bit as the timer comes down? So researchers at Johns Hopkins discovered that people find things faster if they know what to ignore. I'll find the T in this one, but ignore the red.
Yes.
Everyone found it? In case you didn't. This one also is, for those of you that read in English, the first place that you look is top left, so you probably started there. But you might have slowed down, but your search was much more efficient because you knew what not to look for.
After the gorilla, we didn't know if we should trust him.
Right. It's amazing that so many of these things don't work in this audience, and I think that these people are not average, they're smarter than average, and they know that I'm trying to trick them. So they go into it like ready to see. So this is the paradox of directed attention, that we're always really busy. Shifting attention has a very real cost. Not all signals are worth paying attention to, and context sensitivity will always vary. So there's 2 things that we do. One, we hope that people are picking up on subtle early indications of a fault, which is the warning. Hopefully that streamlines the process, but sometimes create bottleneck. Or sorting through an avalanche of data. And unfortunately, when we think we're doing that one, we're oftentimes doing this one. And I don't mean just in the alerts, because if I don't give you enough information, now you have to go through the medical record, and that really is an avalanche of data to figure out what I told you. So there's this idea of alarm philosophy. These are a number of human factors principles that have been validated in alert design. Some are very basic, like don't use more than 10 colors. Use signal words, so things like warning, danger, alert. Make sure that the text in the foreground is contrasted to the background color. But the idea is that you can create something that's learnable so that somebody knows where to look for certain information, they know what it means, and they know how to respond to it. This is my before and after of some of the work that we've been doing with the Clinical Decision Support Work Group. This was an older alert for pregnancy lactation. It says alert, that's good, right? Patient reported she is breastfeeding. Okay? And that's all that you can do, literally, okay? It's not telling you what the drug is that it fired for. It's not telling you what the risk is to the patient. It's not telling you what action to do except go look in the formulary, and we know that's cumbersome as well. The other thing that we didn't realize about this alert is that it only fires once in a 24-hour period. So about a month ago, a physician put in an order, an attending got this alert and thought, oh, okay, let me change to a different medication. When that alert did not pop up on the new medication, she thought, oh, great, that one's good. And it turns out that second medication was actually worse than the first one. And so when we start to rely on automation to tell us when we're wrong, then we're creating even more problems. This is a mock-up of the new alerts that will go live here in the next couple of months. So there's a signal word and it means something. We've created this philosophy where warning means something different than high risk, means something different than notice. It tells you what the drug is, why the alert fired, and it tells you what the risk is, but then goes into more detail. And every medication alert will have these three boxes. Why did the alert go off? What's the risk to the patient? What is the action? And then for the majority of them, giving you an option to continue, cancel, modify. And so we want you to have all the appropriate information, but we also know that some physicians only care about a certain piece of this, and if it always looks the same, now you know where to look. If I only want to know what the action is, then they just look to the bottom. If I only want to know what the risk is, they know to look in the middle. So a lot of research about these problems and very few research about what to do about it. David Woods, who's really famous in cognitive psychology, systems, processing, I'll read a quote from him. Note the paradox at the heart of directed attention. Given that the supervisory agent is loaded by various other task-related demands, how does one interpret information about the potential need to switch attentional focus without interrupting or interfering with the tasks or lines of reasoning already under attentional control? So to state this another way, how can one skillfully ignore a signal that should not shift your attention within the current context without first processing it in case it hasn't been ignored? So there's a couple of ideas. One is sonography, so the idea of incorporating sound. We obviously do this with physiologic monitors, but we have not even started to explore this with alert design in the electronic medical record. And the second is tactile. So one of my old professors, Tom Ferris, who, when he was at the University of Michigan doing his dissertation, created an anesthesiology vest. I'm sure you're aware of this, with tactile function. So we know anesthesiologists are really busy. They have a lot of information coming in. Sometimes they're overloaded. So this was a vest anesthesiologists wore that transmitted vital signs. So you could feel the heart beating on the chest. The blood pressure would go up and down the arm, so you would know if something, one of those vitals went out of a certain threshold, then you would be alerted by that touch. When he did research in a simulation lab, the performance of anesthesiologists increased, but they all hated it. So that's something we talk about all the time. If something's great, but everyone hates it and they're not going to use it, then they're not going to use it, and that's why it's not a thing. Another idea is personalized alerts. So this is from Rothman's Quilt Index for patients at risk of deterioration, but just the idea that maybe you want to look at all of your patients together. Maybe you want to be able to zoom in and look at just one patient. Maybe you want to see heart rate, respiratory rate, temperature all lined up, but maybe you want to see them overlaid on top of each other so you can see how they're interacting. So are we able to customize things in a way that helps people interpret the way that they want to interpret the information? So again, having a lot of questions and talking about research that has yet to be done. There's serious gaps in understanding how to effectively display alert information. And even more to the point, there's little consensus on how alerts and warnings should be generated and displayed. Takeaway messages: patient safety problems are the result of the interaction between people, technology, and the system. So before we can focus on the people and the technology, we have to understand that system. There's a science devoted to understanding how to design technology to support human performance, and it's called human factors engineering. And that research makes it clear that technologies are not solutions, and they should be cognitive aids to support decision making. And I've heard Muge say this a bunch in the recent Q's presentations, that the Q score is not meant to take away clinical judgment. I think it's because we know how important that gut feeling is for a nurse or for a physician, and we can't ever replicate that with technology. And then lastly, the road to patient safety and high quality care runs through performance of you and your staff. If your technology is bad, then your performance will be bad. And if your performance is bad, then quality and safety will suffer. So really paying attention and incorporating this idea of evidence-based and thoughtful design.
Kristen, thank you for that excellent presentation about the role that human factors can play in healthcare, and I just wanted to echo that this was one of the things we thought about in the Value Institute, and why we wanted an expert such as yourself in our system was to help us think about how do we, it's not just enough to create a protocol or to have a data point, but how will this actually interact with humans? How do we encourage humans to do the right things or optimal things? And how do we put this in a very busy, chaotic workload care environment, how to optimize it? And your contributions have been very helpful. What Kristen didn't tell you is that one of the tools that she used for the alert design, she used a validated instrument to help assess the alerts that were going on with the pharmacy alert system. And it turned out that it correlated with the overrides, if I'm not mistaken, that a lot of the alerts that were being overridden were happening because they were of the poor design nature of the alerts themselves. So therefore, demonstrating in very short order how that impacted the clinical care environment. So, so thank you again for your efforts, and hopefully we hope to expand this approach system-wide.
I thought you were going to say the human factors team.
Great job. I love the perspective this brings beyond from the slide to the analysis. I think that one of the things that, just to add another kind of layer of the importance of this, and I mean, this happened literally yesterday, so it's kind of almost but a patient asked me in a room of whose family member was unstable with alarms going off, and we were in the room at the time addressing those abnormalities. They said, well, what about all these alerts going on? And I said, oh, it's a great question. You know, we're addressing them right now. So I kept hitting silence. But when you mentioned the silence button, you know, the silence of the alarm that you ignore versus the silence of the one that you're acknowledging. You mentioned, like, if you're talking to a human, it'd be like, yes, oh, I know that one, or oh, I didn't know that, let me act on it. But what hit me then yesterday, it was new, and we've been thinking about this for a while, but was the patient experience side of it. And for them, whether it's here, the ICU, or somewhere else, they hear alarms, and they either see you respond or ignore or not address them, and that can affect their perception, whether it's true or not, of their care. And when we were, you know, acknowledging alarms and fixing things, and they feel like they feel cared for, when they're like, man, this alarm keeps going off and no one's come in the room for an hour, that presents to them this environment of potentially a negative experience. So I don't think we haven't even addressed that either. We can talk about the patient experience with the provider experience and how those interact with the alarm settings. So it was interesting kind of timing when it happened. I was like, I gotta tell Kristen about this, because she's gonna like this.
Yeah, because it's almost like I'm ignoring this alarm, like I'm ignoring you.
Yeah.
You know, and if you're sitting there and things are beeping and nobody's coming, like, where are they? What if something serious happened?
And all
they're
the
too
family,
busy, they
and all
don't
the
care
family
about
does, is they just stare at your monitor, and they're just staring at the alarms. They're just like, it's going off again.
Yes, Paul.
Well, being a little more cynical maybe than others, and I think you were, some of the things you talked about sort of addressed that, but it seems to me that there'll always be a natural human resistance to almost anything that's introduced into your system. How is that overcome just by the coolness of your alert?
I think it depends on how well it works. Like if people are going to accept it. And we also see generational changes, so we're able to incorporate things now to younger physicians that older physicians they're not as accepting of. Yeah, times are changing. We were talking the other day about the hospital, the goal in 3 or 4 years is to move everyone to an iPhone, nurses. So that you're using this as a barcode scanner, you're using this as your EMR, you're using this as your Vocera, and I think that's going to scare a lot of people who like having, other ways to do things. But if it is more efficient and it's helping us provide better care and saving us costs. But yeah, nobody likes change.
On that note, Paul, I'll add one, that one of the things that's happened in like how much it works, we've learned that certain alarms we all get up and run for. So if there's a call from radiology saying, you gotta check out this patient's CAT scan, like everyone knows you, that's bad. Whereas if it's a lab, potentially, maybe they get ignored because they've learned it doesn't work as well. So you're right, the hesitancy, I think, is not just first pass, but the hesitancy is like, oh, I've learned that I can't trust this thing, so I've learned to get burnt by it and stop running. Whereas the one where you consistently get alarmed and you realize that was a bad thing, like you trust that source. But it changes depending on what that information is. I mean, we've seen that vary in performance depending on what the content was. So it's interesting.
So it's going back also a little to what Paul said. How would you, when you introduce a new alarm or the last thing that you showed about the summer alarm, how do you test it to see whether it works before introducing it to everybody?
Yeah, so I can talk specifically to the alert design, the threefold alerts. And so part of it, I think, is when you build it, making sure it's an interdisciplinary team and everyone feels like they're contributing. So that's pharmacy, it's nursing, it's physicians, it's Value Institute. And then, we don't want to surprise people. And so we're introducing it to the resident quality and patient safety group and getting their feedback on how we can improve it or if they like it. So doing some usability testing there. The tool that Dr. Jackson talked about, we are in the process of scoring the new alerts with that tool, and everything that can be at 100% is, because it's addressed all of these principles of color and wording. So I think trying to get all that buy-in really early on and not just all of a sudden changing to these new alerts is really important. But obviously we want to try out new information. We can pilot it somewhere and then improve it. That's even better. Peter Pronovost is one of my idols in the field of human factors and quality and patient safety. He tells this great story about his son when he was in kindergarten, who came home really upset from school because they had put monsters in the toilet, and the school had changed everything over to automatic flushing toilets, and they didn't tell any of the kids. They're really upset about it. And he used that as an example for introducing new technology. That can't be a surprise. You have to make sure everyone's aware. So try to incorporate that.